So what I'm going to try and do over the next 30 minutes is tell you a little bit about where CTCL is going from the point of view of what's happening on the therapeutic landscape. So first point to make. The CTCL are not like what I just talked about with peripheral T-cell lymphoma, where we have really not a lot of great options, and we're in the midst of trying to figure out what's the best way to treat our patients with minimal marginal drugs. CTCL is the opposite. Even though CTCL is technically a peripheral T-cell lymphoma, the definition of a peripheral T-cell lymphoma is a post-thymic mature T-cell lymphoma that has undergone gene rearrangement of the T-cell receptor. So by definition, the CTCL are really a subtype of PTCL. But the CTCL, as I'll discuss in a moment, have a lot of different therapies, and the strategy to manage these diseases is unlike the strategy to manage any other kind of lymphoma. You treat many forms of lymphoma, aggressive lymphomas, with combination chemotherapy with a hope to cure. In the case of the CTCL, they're more like indolent lymphomas, and many of the paradigms change as a function of the disease. And so we'll talk about how, within the context of CTCL natural history, you may have very indolent forms of the disease that may take you down one therapeutic route, and you may have very aggressive forms of the disease that take you down a distinctly different therapeutic route. So what I'll try and do is just underscore some of those clinical considerations that you use in your mind to think about prognostic subsets of these diseases. And we'll talk about two drugs approved in the United States. I don't know if they're approved here in Saudi Arabia, brentuximab and mogamulizumab. So we'll talk about some of the data from these two trials just because they're approved and they're highly effective therapies. They're randomized phase 3 trials, so their benefit is clearly established. And this is not meant to intimidate you in any way, but there are a lot of other new agents. And we'll just talk about some of those new agents, touching on them. These are not necessarily approved other than, say, romidepsin, but I'm just going to touch on some of these therapies. And the point I will emphasize is if you look at these new therapies, you're going to be hard-pressed to find chemotherapy as the standard, right? So how this disease has changed, and I hope this is how PTCL changes, is we start establishing the basis for using a lot of these other novel precision-targeted drugs or immunotherapies to sort of rewrite how we think about the disease. And if you look at this slide, it sort of presents the T stage, the tumor stage of different types of T-cell lymphoma, of different types of patients with cutaneous T-cell lymphoma. And so very much like what we do in solid tumor, we use the T and M classification. We don't really use that in other blood cancers, but it is used here in CTCL. You can see that patch disease, where you have patches or plaques covering less than 10% of the body surface area, T2 having more than 10%, tumor stage, T3. These patients here, I don't know if you've ever seen them, but in my career, those patients coupled with the gamma delta subpaniculitic T-cell lymphomas represent some of the most horrific forms of lymphoma you can possibly take care of. And then, of course, the Sézary T4 types, and this is the follicular tropic. So what you see here is at survival, 10-year survival as a function of the T stage. So if you have patch plaque disease limited to less than 10% of your body surface area, you have absolutely the same survival as somebody that had no CTCL. So it's a very, very indolent course, and it's treated as such. But you can see how, as the T stage advances, your 10-year survival goes down dramatically. And in fact, when you integrate all the other elements of the staging, and I'm not putting this up for you to memorize it here, but I'm putting it up to make the case that it's very similar to what we see in solid tumor. You have T stage, N stage, M here is very general, visceral involvement, and of course blood stage to pull out the Sézary syndrome. And so when you look at this prognostic category, this T and M classification, you can actually define the stage of the disease. The stage of the disease here is important because it helps establish what the prognosis of those patients happen to be. And so just as you look at overall survival, it's an absolutely perfect overall survival stratification. Patients with early stage disease have pretty good long-term survival. Patients with stage 4 disease generally very poor. If you look at the risk of progression, it's the exact mirror image. The risk of progression goes up as a function of that stage, and likewise overall survival by various risk groups. So when you think about your patients with cutaneous T-cell lymphoma, very, very important in your head is to understand exactly where they sit with regard to their clinical stage of disease. And the algorithms for this disease, I'm not going to belabor the details here. I'm simply putting them up to underscore some points. So first is thinking about all of these elements of stage, comorbidity, symptoms. Symptoms are an extremely important feature of this disease. And for those of you that take care of it, you know that patients will come in itching and have lots and lots of pruritus and lots of symptoms. And we'll talk about response criteria and how one evaluates response, but it's not that common that these kinds of quality of life scales are built into our assessment of response, right? And so depending upon the stage and the need for symptom control, there's a whole variety of regimens. And they're really, while different centers and different doctors may have their own algorithm in their head in terms of how they proceed, there's really not one unified algorithm in terms of going from skin-directed therapy to external beam to total skin electron beam. There's no real algorithm out there. So it's really left to the doc to try to decipher which of these therapies at any given moment in time is sufficient to control the symptoms and deal with the stage of the disease. When you look at patients that have advanced stage disease all the way over to patients with large cell transformation, these are the patients that can develop tumor stage disease, and these large cell transformations are extremely difficult to manage, extremely difficult. And you can see that this would be the one scenario where encouragement to get on a clinical trial or combination chemotherapy is in order, even in some cases autologous stem cell transplantation. So the algorithm is actually tailored to the clinical scenario, and you need to actually understand that clinical staging system with regard to understanding the risk of the patient. So it's very clear there's a lot of new drugs. I won't belabor all of these. We're going to talk about some of them. But this table is unlike what I would share with you for PTCL, where we don't really have all these different kinds of agents. So there's a lot of drugs out there with very unique mechanisms of action. You'll see chemotherapy is not prominently featured. But the Alcanza study was actually a very important randomized clinical study looking at brentuximab against dealer's choice. And here, dealer's choice was actually methotrexate or bixarotene. All these patients were treated that had to have CD30 positive mycosis fungoides or primary cutaneous anaplastic large cell lymphoma. We can talk about the anaplastic large cell lymphomas, but you need to, in your mind, distinguish them from the systemic anaplastic large cell lymphomas. How many types of anaplastic large cell lymphoma are going to be in the next iteration of the WHO classification? I'll say a number, you raise a hand. 2, 3, 4. My God, you guys. 4, we see a 4. 5. All right, you're very quiet or you've got postprandial narcosis. The answer is it's going to be like 5. So there's ALK negative systemic, there's ALK positive systemic, there's, what else? Breast implant associated, right? There's primary cutaneous. But guess what? In the world of ALK negative anaplastic large cell lymphoma, the DUSP22s, you know that ALK negative has an inferior prognosis to ALK positive. So because the DUSP22s are considered now to be a favorable subset of the ALK negative, WHO has pulled it out as a separate entity. So in the case of systemic ALK negative anaplastic large cell lymphoma, we've always thought of those as bad players, having a prognosis intermediate between ALK positive and all the other PTCL. The DUSP22s have a prognosis like the ALK positives. So now 5 types of anaplastic large cell lymphoma. It's so critically important for you to know that because you will see patients that have systemic disease. Maybe they show up with a skin lesion. You'll see patients with a skin lesion that might show up with a node lesion. You really need to spend time to figure out what kind of anaplastic large cell lymphoma they have because you will treat them differently. Sorry for the diversion, but it's an important point. And so we'll talk about the endpoints of this study, but what I want you to pay attention to in this randomized study is they used a primary endpoint of overall response rate 4. And I don't know if you're familiar with that, but it's the first study and right now the only one that's used this as an endpoint. We'll talk about it. The CTCL field is in a state of controversy about trying to define what the right way to assess response is. When you look at the overall toxicity of the regimens, it's pretty well tolerated. And therein lies point number one. When you're developing regimens for CTCL, most of the therapies tend to be monotherapies that are well tolerated. So the platform is not to think about combination therapies or very toxic forms of the drug. We'll talk about one of those drugs in a moment, pralatrexate, which was studied as a monotherapy, but the dose we use in PTCL was deemed to be too toxic for those docs that take care of CTCL. So studies were done to back off on that dose to see where the right level of toxicity and activity exists. In the case of brentuximab, this is what you would exactly expect. You see a very low incidence with methotrexate and bixarotene. You see a significant percent of patients having grade 3-4, having any grade toxicity, but here in green, the grade 3-4. Most of these other toxicities are actually fairly manageable, though there is a little bit more toxicity associated with brentuximab versus the other two drugs. And when you look at the waterfall plot, you don't need to be a cutaneous T-cell lymphoma doc to realize that brentuximab, in this case, looking at the patients with MF versus primary cutaneous anaplastic large cell lymphoma, have much deeper and better responses across the board. Look at the patients with primary cutaneous anaplastic large cell lymphoma, essentially almost all of them doing very well. Remember the anaplastic large cell lymphoma as a group, including those breast implant forms of the disease, all are notable for gross expression of CD30. Basically, those cells have 100% CD30. It's where you get into the other types of T-cell lymphoma that the CD30 positivity can fall off. And again, you can see the differences with a marked superiority for the waterfall plot seen with brentuximab. When you look at the overall response rates, again, we can look at overall response rate 4. What ORR4 really means is what percent of patients are maintaining that response by the 4th month. So historically, how a lot of this was determined is you just look at overall response. Did you respond? Did you not respond? And so that's why that number is a little bit higher, 67% versus 56% of patients who held that response by the 4th month. You can see over here, with regard to the physician's choice, those numbers are 13 versus 20%. So a very clear therapeutic advantage in the intention to treat population. And again, just as I alluded to earlier, when you look at mycosis fungoides as a function of stage, you'll actually see what you always try to look for is that those response rate that you see in the intention to treat population or in the low risk stage population, you like to see those response rates carry through to the high risk patients. And in fact, that's what we see. You see the patients with stage 1A to 2B disease having pretty good response rates, certainly a lot better than what you see in the investigator's choice. And here, of course, the numbers get very tiny, so it's awfully hard to say anything, but amongst those patients with those high-risk forms of CTCL, they tend to do pretty well. And again, when you look at the progression-free survival, there's a highly statistically significant advantage for the patients that got brentuximab versus dealer's choice. So these are the data that actually gave rise to the approval of brentuximab. Now, Miles Prince from Melbourne gave a great talk at the T-cell lymphoma forum talking about response criteria in CTCL. And he made the case that the current use of MSWAT, the current way of assessing response, has its limitations. And he's trying to sort of increase the dialogue and the narrative around how should we be looking at response going forward. So he clearly made the point that MSWAT will demonstrate drugs that have clear biological impact, though there are a lot of deficiencies in MSWAT that may not be apparent to you when you're in the clinic or reading about it. How many people here, don't be bashful, how many people here have used MSWAT in the assessment of CTCL responses? Nobody. What do you use? Do you see CTCL? What do you use your nose and say, smells like a response? That may work a little better than MSWAT.
From their pathologist.
From the pathologist tells them if they have a response?
Yeah,
Say?
after failure of third line.
Dermatologist. I see, yes.
They refer for either
I see.
Vedotin, rituximab, or for the
Yep.
DLI inhibitor.
I got it. And that can be an issue, right? Because dermatologists can be very chemo nervous and averse, right? And so I've always, I don't mind managing these patients, and I get a little nervous when dermatologists start prescribing chemotherapy, but there are differences in terms of how people approach the disease. So in the case of the MSWAT deficiencies, there's differential weighting of patch versus plaque versus tumor stage disease. Evaluating response by MSWAT gets very difficult if you have erythroderma. It gives no insight into whether there's meaningful, durable impact, hence overall response versus ORR4. And importantly, MSWAT does not address benefit if patients do not meet PR. And so what Miles presented the case for was not just looking at MSWAT and these kinds of criteria, but actually looking at time to next treatment as sort of one of those benchmarks to pay attention to in terms of evaluating the response. And so just to drill home that point around the ORR4, you can see here head-to-head comparison. So of course, those patients achieving a CR or PR lasting 6 months versus a patient that had a CR/PR lasting only a few months, this patient would not be counted as having had a response in Alcanza, but this patient would, for example. And so it's just an important detail that as you read these studies and you try to cross-compare the data you've seen with Alcanza versus the data you see with other drugs, just keep in mind now that a lot of these trials may be using different endpoints to assess the benefit. So I'm not going to belabor that. Now, the second drug approved for the disease is one that targets CCR4. And this is one we got involved with way, way long ago when CCR4 began to emerge as a important target. And so we know that there are ways to target CCR4. So mogamulizumab, which is a humanized defucosylated monoclonal antibody with enhanced ADCC. So what all that means is the ADCC part of the FC domain, the antibody-dependent cellular cytotoxicity, it has been shown that removing the glucose residues from the FC domain of the antibody, so it's the Y, so it's the stem of the Y on the antibody, makes the antibody much, much more efficient at facilitating ADCC. And that's obinutuzumab, it's ublituximab, it's other CD20s. Rituximab is not that. So these class of antibodies tend to be referred to sometimes as glyco-engineered. So the manufacturing process takes these sugars, the most common would put on is fucose. It takes those sugars off the FC domain and gives the antibody much, much better antibody-dependent cellular cytotoxicity. And so all of that is symbolized here. We know that CCR4 is expressed on malignant T cells. Mogamulizumab is a humanized antibody targeting CCR4, and it's approved in Japan for the treatment of HTLV1 ATLL. And so the clinical trial that gave rise to the approval of MOGA was MAVERICK. And MAVERICK was also another randomized phase 3 clinical trial looking at mogamulizumab versus vorinostat. Now, the casual observer could say, vorinostat? Is vorinostat approved in Saudi Arabia? No. So vorinostat, I helped develop vorinostat way back when at Sloan with Paul Mark. So vorinostat was one of the first histone deacetylase inhibitors to get into the clinic. It's an oral hydroxamic acid that was approved for the treatment of cutaneous T-cell lymphoma. People looking at this trial could reasonably criticize the selection of the control arm. Vorinostat was a good drug. The FDA at the time said, well, there's no data that it's any better or any worse than any other drug. So it was established as a reasonable comparator for regulatory purposes at the FDA. Patients with histologically confirmed MF or Sézary syndrome and failed at least one prior systemic therapy without evidence of large cell transformation were eligible for the clinical trial. And so if you look at the MAVERICK data, the progression-free survival, again, highly statistically significant, 7 months versus 3.1 months, the hazard ratio 0.53. When you look at patient-reported symptom reduction, so this has become pretty important in conducting a lot of different CTCL studies. So are you not just improving the disappearance of the disease, but what are you doing for the symptoms? And I'll tell you, when I was I was the first person to give vorinostat to any patient. And one of the first things I saw, God is my judge, was treating patients with Hodgkin lymphoma. And when you saw patients with Hodgkin lymphoma, you know those patients that have bad itch, they just say, Doc, I want to die tomorrow because I can't deal with the pruritus. So we had a lot of patients that got vorinostat. And the first thing they told me after starting the pill, my itch went away. And so it's sort of very, very interesting. And of course, around that time, romidepsin was emerging from the data at the NCI and CTCL, and that's what prodded us to think about pursuing vorinostat and CTCL. So the early experiences with the drug are very interesting. But what you see here is the symptom improvement scale, everything favoring the outcome with mogamulizumab. The progression-free survival, 7 months for mogamulizumab, better response in blood over lymph nodes. That's another interesting feature for many drugs studied in CTCL. They may have better compartmental effects. They're not the same across the board, and the median time to worsening was 27 versus 7 months. So a lot of data, both symptom data as well as response data, demonstrating the superiority of mogamulizumab. When you look at the safety summary, you can see here, in general, a pretty well-tolerated drug. Rash tends to be one of the more common side effects of the drug, and here you can see all grades. The good news is only about 5% of those tend to be grade 3 or 4, and you can see that that is higher than what we see with vorinostat, both with regard to total grade skin toxicity compared to vorinostat. Everything else has a little bit worse incidence here in terms of all grade, but when you look at the grade 3-4, it's not that much inferior. So let's talk briefly about a number of the new drugs. And again, I'm not going to go into too much detail. I just want to sort of put these things on your radar so when you read about them in the literature or you hear about them at ASH, you'll say, good, I knew this was coming along. It's nice to see that we got more data. Many of you know that targeting the IL-2 receptor, CD25, like the ONTAC, you remember ONTAC, the CD25 diphtheria toxin. And so it's become still a very important target in the field of CTCL, and a drug called E777 is a fusion protein targeting the IL-2 receptor. And so this is a small study, about 21 patients, the efficacy population here, 18. You see the overall response rate, not bad, about 44%. The overall population over here, 31. Only one patient achieving CR. So interesting response rate, not exactly a great complete response rate. You can see the waterfall plot here. So you see the majority of patients have some downward deflection, but a minority of those patients go on to actually have meet the criteria for response. This was a phase 1 study, so there were patients getting lots of different doses of the drug, which may account for some of the noise over here. But nonetheless, there are patients that did have pretty dramatic responses. As you can see in this picture here, this is a very dramatic response, and by the PET scan. When you look at the waterfall plot, again, this is looking at changes in the tumor volume. This is including patients with PTCL and CTCL. And so the patients in PTCL here in blue, CTCL in orange, still shows a pretty not terrible response rate. I don't view it as any better or worse than anything else in PTCL. So the overall response rate was 36%, 41% in PTCL, 31% in CTCL, extremely small numbers. Here you can see some of the evidence for the progression-free survival. This is on the horizon. This is data that's evolving. I think we'll need more time and more patience to be able to understand whether this is the kind of drug that's going to have a role. Pralatrexate, is a drug that I both invented and developed. It was the first drug to be approved in PTCL in the United States back in 2009. When we began thinking about trying to explore it for use in CTCL, the first thing that we had to do was sort of revisit the dose and schedule. The drug can be associated with some mucositis. Otherwise, that's the big toxicity. And so we actually did sort of a reverse phase 1. You can see here cohort 1, and then we moved on. So here we're kind of starting with the MTD dose that we had in PTCL. So 2 patients, 100% response rate, both of them responded. But because of the issue related to toxicity, we began a program to dose reduce. And this is one of the interesting features of this drug that still astounds me today, and we've made new versions of this drug that I think will be even better. In that, establishing a dose response for this drug has been really hard. because we do see responses down at 20 milligrams per meter squared. We had seen some responses down here, admittedly only one down here, but at low doses you do tend to see responses. We have seen responses at 15. And so the question in CTCL is how do we pick these particular dose levels and move on? But nonetheless, this never really got legs after this phase 1 experience. It was documented to have effect, but given the competitive and climate at the time, this kind of stopped there. I think the newer formulations we're making could be better because we can give the drug less frequently with pretty good exposure. Now, this is another drug, and I don't know if you've heard about the CD47 targeted drugs, but this is one that we were also involved in back early in the day. And most of you are probably aware that tumor cells have a protein on the surface called CD47. And the way to think about CD47 is it's a do not eat me signal. It's a signal that tells the macrophage, don't digest me. So the ability to induce phagocytosis by a macrophage is actually inhibited by the expression of CD47. So CD47 on the tumor cell interacts with a protein on the macrophage called SERP-alpha. It's this interaction that instructs the tumor cell to not touch the tumor cell. It instructs the macrophage not to hit the tumor cell. Is that clear? And so what happened, so this target has been getting a lot of attention. There are now a number of drugs out there targeting CD47. There's the drug that was developed by the company 47 that was bought by Gilead, which is an antibody. But another way to therapeutically intervene here, which was the approach developed by Trillium, was to actually make the protein a SERP-alpha protein that would mimic the SERP-alpha on the macrophage, bind to the and block an anti-SERP-alpha on the macrophage that would blind the macrophage. And so this way they could actually intervene to induce the macrophage to phagocytose the tumor cells. Now, there have been a couple of ways, and early on when we did this phase 1 study, I'll show you the pictures, the patients that had some of the most dramatic responses were patients that had large cell transformation of their mycosis fungoides. Remember, I told you that was a pretty difficult clinical situation to manage. The other strategy was one that was adopted by Christiane Queerfield out at City of Hope. And she's a dermatologist that was interested in injecting the TTI 621, that's the SERP-alpha analog, into the tumor cells directly. Now, as a therapeutic strategy, you might think, well, that's going to be a pain in the neck if you have a lot of lesions on the skin. But she was looking to do some biology. She wanted to inject it and see if she could understand how the drug was working in the tumor microenvironment. So she developed an algorithm for treating patients at a function of these different doses. You can see the number of patients she treated here. She treated 15 patients with CTCL. She found one patient had a PR, one had a complete remission out of 6 evaluable patients. 2 responding patients were bridged to an allogeneic stem cell transplant. So between her intralesional experience and our systemic intravenous experience, it was clear that there is activity with these macrophage inhibiting, facilitating drugs. Now, this gives you an idea of the drug. This is the actual molecule, and you can see it has built into it. It's a fusion protein. So on this top end here, you have the CD47 binding domain, binds to the human SERP-alpha on the macrophage. This is the human Ig domain here, and that is delivers an eat me signal to the tumor cell. Okay, so this is the actual intervention, and these are my patients. These are my actual patients. This is a very interesting confocal microscopy. If you can see, the tumor cells are in green, the macrophage is in red, and when you treat with the drug, what you see is the tumor cells inside the macrophages. It's crazy, right? So first time I saw that, I was like, okay, I want to study this drug. That was super interesting. But this is an actual patient. And these are patients that have tumor stage mycosis fungoides. You may not be able to appreciate the third dimension, but this is a patient that had tumors all over their back. Now, this is not a patient you're going to take the time to intralesionally inject in a prescribed way. They got the systemic therapy. They had a huge regression, PET scan positive to negative. This is a patient that had tumor MF. It was eating a hole in his freaking neck. Look at that. these cases, you have to have a strong stomach, and you can't see them after or before lunch. These patients get very sick, and you could see here, basically holes from the tumor. And look at that. Basically healed over the entire lesion with the drug. So these patients had responses. They weren't short-lived. They were very long-lived responses. So this drug, there's new versions of it. This is a case from Christian, who did an intralesional injection. This is a guy that had it on the foot. You can see by week 4, a near eradication of all these tumors that were just invasively eating away the stroma of the skin. These are the cases here. So very, very dramatic responses. There is now second and third generations of the Trillium drug that are developed. I think Pfizer bought Trillium and is now put together their own program, but I think it's a pretty promising drug on the horizon. PD-1 continues to be a drug of interest in the T-cell malignancies. For me, it remains to be defined what the response rates for the checkpoint inhibitors are going to be. But here you can see a classic waterfall plot. So this is one experience looking at pembrolizumab in MF and Sézary syndrome. If you look at changes in the tumor, you see the spider graph here, some patients having marked reductions, some patients growing. But small patient experience of the 9 patients evaluable, you can see the waterfall plot. A lot of patients with PR, 1 with CR, a couple had progression. That overall response rate was 38%. The time to response was about 11 weeks. Median progression-free survival not reached. Response rate was higher in patients with MF than Sézary syndrome. With all that's happening in CTCL, it's not clear to me that pembrolizumab is going to be that drug on the horizon that's going to have a very clear role. If it does have a role, it may be reminiscent or similar to what I told you about with the combined epigenetic therapy, where you're stimulating the immune microenvironment to favor this response. If you ask Owen today, what do you see is the vision for epigenetic therapy? Somebody was asking me at lunch. I think as drugs by themselves, they're going to be okay drugs. But I think that the real value, the value as defined by people like Ari Melnick and people like Steve Balin at Hopkins, is they're very, very, very good drugs to prime the tumor cell and the tumor microenvironment. They make the tumor cell more sensitive to chemo, and they prime the tumor microenvironment to be responsive to immunologic therapies. And that's what we've seen in the lab, that's what we've seen in the clinic, and I think that's likely to be the future of epigenetic therapies. Now, another class of drugs that's gotten a lot of attention is duvelisib. Do you have PI3K inhibitors approved here? So you are all probably no doubt familiar with all of the luggage that goes with PI3K inhibitors, and I've been vested in this for a long time. In the United States, these drugs are under attack by the FDA. The FDA, as of last Friday, pulled the last one off the market. Idelalisib, duvelisib, just had a meeting before the Oncology Drug Advisory Committee at FDA, where there was a vote to actually pull it off the market. Many of the other PI3 inhibitors in development were stopped from filing their application, all because of this issue around the autoimmune toxicity seen with the PI3 inhibitors. And I can talk a lot about what the mechanism of that is and how I think we should approach it. But nonetheless, duvelisib is a drug that has demonstrated some activity in PTCL. And there are single-arm registrational studies looking to get it approved in the United States in PTCL. But I think those studies may have just died as of last Friday, because the FDA made it clear you cannot get a PI3K inhibitor approved in the United States in the absence of a randomized study. So any single-arm studies with these drugs, pay attention, are probably not going to meet the bar for approval. But nonetheless, if you look at all the T-cell lymphomas in this study, you see a response rate a little bit over 40%. You can see the progression-free survival, patients with PTCL versus CTCL. Again, you can see the overall survival where patients with PCCL and CTCL. So the overall survival not reached, single-arm study, hard to say. About 80% of patients were alive at 2 months. Median progression-free survival for CTCL, about 4 months. So given its activity by itself, I don't think this is going to be a home run drug. And
1 minute.
1 minute, got it. We've already talked about some of this data, but I'm just underscoring it. We talked about tolinapant We talked a little bit about its complex mechanism of action. But again, just like I showed you, more patients, but only about a 30% response rate in CTCL. So it's another one of those sort of average drugs coming along, probably never going to have a role by itself. But it's possible, as I shared with you earlier, new data. You see all this red? This is a good thing if you study synergy in pharmacology. So unbelievable synergy. And even in CTCL, these are CTCL lines, anaplastic large cell lymphoma, profound synergy. And so now there's plans in CTCL to start tolinapant with decitabine. This is my own effort to tell you yet again how we're developing the nanoromidepsin in CTCL and PTCL, where I think this could be a very interesting model to develop, and we could think about putting drugs together. And the role of stem cell transplant. Really, the role of stem cell transplant here for patients with T-cell lymphoma is largely resigned to those patients that have evidence of large cell transformation. You can see here some of the data with respect to CTCL 5-year overall survival. So there is some benefit from transplantation. And you can see over here CTCL versus PTCL. So this tends to be really confined to one or two patients, one or two types of patients. So these are very heterogeneous disorders. You have to look at the clinical presentation to understand risk. A vast repertoire of new non-chemotherapy directed treatments are changing the landscape. Treatment focus is very different from that I talked about in PTCL. Systemic therapies have limited role for many patients. Transplant, limited restricted role. Referral to local regional centers is highly recommended. And with that, I'll put in a cheap plug for this book that Zinzani, Kim, and I put out. There's lots of chapters on CTCL, and this is the first textbook on T-cell lymphoma, both PTCL and CTCL. If you're interested in a copy, email me, and I'll email you back a discount to get the book.
Thank you so much.
Thank you.